Hi everybody, Dr. Anna Moran here. It's a pleasure to be presenting this research, which has been a lovely gift to be able to undertake and analyse. I'd like to acknowledge the traditional owners of the land upon which I stand today, the Waywuru and Dadaroa people. I would like to commit to working alongside First Nations peoples for reconciliation, justice and healing. I'd like to acknowledge the team that has worked with me to bring this to you today. That's Dr. Kath Cosgrave, Dr. Olivia King, Dr. Christina Malatsky, Rhiannon Memory, Dr. Rosalie Boyce and Dr. Susan Nankaro. And my study is examining these hidden heroes who are solving wicked complex rural health problems using some non-traditional allied health roles. It's a qualitative study. These are the kinds of things I'm going to talk about today. And I'm going to point out this image to the left here. That's a person standing right in the center of the screen. And the arrows are all the different interventions and ways that we should be helping that person. And we're going to talk about the significance of that as we move along. So what are rural needs? We're all 100% familiar with this, and we're all talking about it at the conference today. The rural client has these kinds of issues on the right-hand side here, and they're highly prevalent. These issues here, including low engagement with healthcare and less healthy behaviours, poor access to healthcare, etc., contribute to some of these outcomes that we can see down the bottom here. But we can't forget that the rural context also contributes to and compounds a number of these problems here, in particular that we can't attract, recruit and retain a sufficient number of health professionals to really meet those needs, and we're seeing often under-resourced infrastructure in these rural areas. So what do we do about it? There's multiple things we can do about it. We're all talking about it at this conference. It might be a number of these things on the left-hand side here, but this study focuses on these things on the right-hand side here, in particular, social determinants of health interventions. So the challenge for the presentation today is to take your professional hat off and stop thinking about who should be delivering interventions to clients with complex needs, and rather think about what is required to deliver interventions that can meet complex needs. Flicking back to this slide here, this is the challenge. Often we think about who should be delivering care in terms of different professionals: a nurse, a doctor, a physio, a social worker, an OT, whoever. That's how we often think about who should deliver care. But again, what we should be considering is what is required to deliver this care. Research that we've done in the past looking at complex client needs has identified that there are two sides to the coin, and we know this already when we work in our professional settings. On one side of the coin are all our softer capabilities, those qualities, attributes and values. You can read them all here on the left-hand side: being versatile, adaptable, respectful, being an enabler. On the right-hand side here are our technical skills, and it's the combination of our technical skills that we bring into our workplace around our clients and our qualities, our softer attributes and capabilities, when they come together, surround the person and the needs in order to meet those. At the central thesis of today's research is that we are looking at the fact that to truly meet the needs of complex rural clients, practitioners need a set of core attributes and softer technical skills rather than a specific practitioner to deliver care. This brings me to part of the background information. The reason why this was such a fascinating topic to explore, and one that I felt you needed to understand a little bit more about, was around the sociology of the professions. And I draw your attention to Susan Nankaro and Dr. Alan Borthwick. Those two are leaders and experts in the understanding of how professions form and create authority and come into existence. And so I refer you to their work, please. But today we're just touching on it briefly. This concept of non-traditional practitioners, or those who have an interesting set of capabilities and softer technical skills, forms the notion of the post-professional workforce. They are those that have adopted new, flexible roles that are designed to meet the specific needs of the context in which they are working. The full definition is when qualified health professionals from a range of clinical backgrounds, so we look at these guys on the left-hand side here, they might be a nurse, a doctor, or an allied health professional. So they come from a clinical background, but they move into a new space, and you see on the right-hand side here, they've lost their color and they've merged together as a new group. They've adopted new skills to become part of a new workforce with common skills and a shared title. However, they still maintain their primary professional identity. And a really good example of those who've moved from the left-hand side to the right-hand side are diabetes educators. They have come into a group, there might be nurses, podiatrists, dietitians, who form that diabetes educator team. They are recognised as diabetes educators. They deliver services around clients who have diabetes needs. So they've taken off their professional hats, so to speak, and they've come together as a group around a particular clinical problem or clinical need. What we're talking about in this research, however, are those that have taken off their professional hats, so to speak, and we can see them all on the left-hand side here, and formed a group of complex care practitioners. Now, the difference between the diabetes educators and this group is that the diabetes educator movement put quite a bit of scaffolding around that, and we can thank our nursing workforce for that. They put a big professional boundary around who this group is, what they do, what they can't do. And that hasn't happened as yet with these complex care practitioners. And again, you really need to understand the sociology of the professions to understand why or why not that happens, and some of the benefits, but also some of the downsides to forming a strong professional boundary around a new group of the workforce. And again, I'll refer you to Susan and Alan's work for that. So this study focused on a number of different things. It came about via looking at data in the Victorian Allied Health Workforce Research Project. That's that awful acronym right there. And this, what I'm presenting today, is trying to just focus your attention on the interviews and focus groups. As you can see on the left-hand side there, over 6,000 items of data in the Victorian Allied Health Workforce Project. I just wanted to go through and look at who identified as somebody providing care that was in a non-traditional capacity, and you can see there's not many of them that identified as that. Many people still identified as just being a primary professional. So the types of titles that we saw in the Victorian data set were these. You will be familiar with those types of terms. And the types of practitioners that worked in those roles were generally OTs and social workers, but a raft of other types of allied health professionals as well. So in this study, we interviewed 22 AHPs who were working in those roles, directors and managers, and these guys delivered services to people living in areas MM2 to MM5. As you can see down the bottom here, these professionals worked in a raft of different types of services, including advanced allied health practitioner roles in regional health services, health independence programs, health independence coordinators, care coordination teams, complex care teams, etc. The advanced allied health practitioner roles were quite unique and novel. They were introduced to an acute setting, but they were considered a complex care coordinator in the acute setting. We used framework analysis to analyse our findings. So, who do this group of professional help? So the answer to that is that they help rural clients with complex or high-level needs requiring complex, multifaceted support. Typically, they were the very elderly or those in palliative care, patients with interrelated mental and physical health-related issues, or those who struggled to engage effectively with healthcare services. Sound familiar? The services are designed to keep clients in their own homes, reduce hospital admissions, and enable them to self-manage their conditions and their lives, which I think is the key point to these clients. These are some quotes from our interviewees. They are people that didn't really fit boxes. They have very messy, psychosocial, complicated personal situations or family situations. Sort of a high needs group who have the mix of poor health but also challenging social or psychosocial circumstances. So what do they do? The main activities that our complex care or non-traditional role allied health practitioners undertook fell into four main categories. Firstly was around assessing suitability for the program and assessing needs, delivering care and supporting their multidisciplinary team members in doing that, working with clients and carers to manage their conditions, and coordinating all forms of medical and lifestyle support that was needed by these clients. Here are some quotes to describe exactly the kinds of things that they did. We gathered a little bit of case study information, and I just wanted to point out this list here at the bottom of the type of input that this one complex care provider provided to a client. They did health coaching, navigating the health service, smoking cessation coaching, so motivational interviewing in there as well. They did some dysphagia reviewing, chronic pain strategies, equipment, so liaising with the OT, and cognitive screening. So you can see a huge list of interventions that don't fit in that technical skill set. And I'll say that this person was a speech therapist, and if you think of what a speech therapist does, there's only really one item on here that would sit in that very specific technical skill set, where everything else sits in a broader client supporting technical skill set. What impact do these roles have? This is a great quote that identifies that the client has had no new admissions to hospital since they were part of the health coordination team, and no significant flare-ups of their COPD. He's reduced his smoking quantity, he's continued his walking for daily exercise, and they are more confident and exhibit greater capacity to navigate the health system. So what impact do they have on clients? The main impact is that they appear to be have a vastly improved understanding of and ability to meet their own needs, whatever they may be. We've got a guy at the moment who has a very high use of pain medication. He's probably a high hospital risk, so we're not going to see much change in that. But coming off his medication and participating in an exercise group, he's actually much less hostile on the phone, and he's happy to engage with the health service, which is huge for him. On the health service, we see the main impact as a considerable time saver for those other health professionals working in other parts of the healthcare organisation, and also the fact that it's really difficult to demonstrate the impact of these roles on the healthcare organisation, but often it's when that role isn't there that impact is so strong. So often people in these kind of roles, they're hidden heroes, and the value of them aren't really known until you remove it. So what's the impact on AHPs themselves? Many of the participants stress that they find their roles highly rewarding, suggesting that this love of their jobs contributes to their success in them and their willingness to stay despite drawbacks such as limited career opportunities. I just love working with these people. I really enjoy the breadth and autonomy of the work I get to do. So how is value demonstrated in these roles? Participants conceptualize the value generated by these roles mainly in terms of qualitative patient outcomes, including effectively engaging with the healthcare service. Value is also identified in terms of referrals to the program, because these were seen as evidence that others in the healthcare system acknowledged their benefits. So I guess from a bean counter perspective, the organisation values us keeping people out of hospital, which is actually quite hard to measure. The other value is that if the client's problem looks too hard, they ring us. So what kind of mechanisms enable these complex care practitioners to make that impact on their clients and on the healthcare system? Well, firstly, it's to do with those softer skills, those capabilities and attributes. So let's have a look here at the two sides of the coin. On the top is the more softer technical skills that are required, and on the bottom are those capabilities and values and attributes. So as you can see here, a number of different skills and knowledge required here. COPD knowledge, how to self-manage, smoking cessation, motivational interviewing, dysphagia assessment and therapy, cognitive assessment and therapy, general knowledge of chronic pain, referral pathways and knowledge of the health system, health literacy strategies. What kinds of capabilities? Flexibility in the approach, non-judgmental approach, rapport building, clear communication, including understanding of cognitive needs and problem solving around the patient's needs, skills, and changing situation. So we added to our list of those that we had seen previously in our research, and you'll see here some of the words that came up quite frequently in bold on the left-hand side, and this whole list on the right-hand side of different skills that were identified, those softer but really important technical skills that these clinicians, moving from their discipline-specific role into this post-professional workforce where they were coordinating care around people with complex needs, required this list of technical skills over here on the right-hand side. So a fairly expert workforce we're dealing with here. What else enabled these guys to be successful? Well, it was pointed out, and I have to say I only interviewed allied health professionals, there was a reason for that it's the allied health capability of looking at a problem holistically that actually enabled them to impart such impact on their clients. And you can see that described here in this quote. One really important mechanism that also enabled these guys to be impactful was system flexibility. It doesn't exist everywhere, but there seemed to be a recognition in these kinds of teams that they needed to have less fixed time frames with which to work with their clients, and that was a significant mechanism that enabled these teams to work really well with their clients and to get the outcomes that they saw. So that's it, problem solved, awesome, we can move on, but not quite. There are some mechanisms that are actually holding these roles back, and I'll just go through these briefly here. Number one, and the biggest issue, is that there is no formal career structure for allied health professionals in these roles, and very, very limited career opportunities for these guys. It's not recognised in the EBA, and generally the level of skill required to undertake these kinds of roles is not recognised by the healthcare system. In fact, we saw most allied health professionals working in these roles in a grade 2 role. Very few in a grade 3. One group had just been promoted into a grade 3 role, and that was because the nurses in their team argued that they should be graded higher than they were, and so allied health piggybacked on the nurses taking their case to the organisation. Here are just a couple of quotes here that explain that. If you come in early in your career to one of these roles, and that's the kind of work you do, you are pretty much stuck. We have no career progression. One of the other disturbing parts of the conversations I had with these practitioners was they often have difficulty maintaining their professional registration. As you can see, professional registration often relies very heavily on those profession-specific technical skills and doesn't recognise some of these broader ones. Now, this is a big problem for these guys. They're working hard to decipher how they go about addressing that. And then even more disturbingly was that they found that they had quite a lot of skirmishes with people not just in the organisation but in their own professional discipline who didn't understand what they were doing or why they would do something that wasn't entirely related to their profession-specific role. Now, we talk a lot in allied health about allied health roles not being valued or recognised by the healthcare system for what they provide. Well, think about these practitioners who've left behind their allied health identity in some way and moved into a whole new kind of category of worker. So we've got work to do being recognised as allied health professionals. These guys are on the back foot even more, trying to be recognised as a group of professionals who haven't been recognised by the system, not even formally. And finally, we see this everywhere, but again, wrapped up in that idea that these professionals do not align themselves or identify just with a professional group, but rather with a new group of workers. They're really on the back foot with arguing for resources for their team. So let's have a think about this in summary. We've decided that these roles are ideally configured to meet the needs of complex rural clients. I think we can all agree there. Essentially because practitioners can let go of their professional identity and meet people where they are at. But it's at the detriment, or it comes at a price to the individual professional. There's very limited career opportunities, hard to maintain professional registration, attitudes from other professional peers, etc., etc. This quote summarised this beautifully. I've got 22 years experience and the other allied health professional probably has 30. Both of us have a master's. We've hit the ceiling at the moment. They are both grade 2. So our group of complex care coordinators who are truly able to meet rural client needs because of their relatively flexible roles exist in a healthcare system that's generally established around rewarding professional roles themselves. And again, that term professional project, please refer to Susan and Alan's work. But we do really need to retain and value these practitioners, and they deserve a career pathway. So what can we do about it? Well, firstly, we need to invest in getting these roles formally recognised. And there are a number of different ways that you might consider doing that, but I do urge you to consider, if you are in a leadership position in your organisation, have a think of ways that you can get these roles formally recognised. Secondly, there's not enough. And this comes down to the fact that these roles are really hard to communicate to the rest of the organisation, because everybody's so used to thinking about a single discipline and not a new group of workers. So you need to advocate for more. That might be to do with some brand promotion locally of who the team is and what they do. And you can do that through impact narratives that describe and clearly articulate the downstream impact that these roles have on the hospital and the community and the client themselves. Some examples of how you might want to do that are to read this amazing report on the Sarah website. Lists everything you can possibly think about that would argue the case for these practitioners. There's also quite a lot of evidence out there, and I would go to meta-analyses and systematic reviews for this kind of stuff that talks about the impact of medication non-adherence. You can describe the value of the impact that your practitioners make on client lives in this way. So these are just some examples about how you could measure the impact and value of these roles, not just for your health service, but on your clients' lives. Flicking through really quickly here, I'm just going to stop on this slide though. In terms of an impact narrative, if you look up the top there, this was the impact that one care coordinator had on their client, and if you remember, it was to reduce his smoking quantity. You can put some really nice statistics around that, taking from a meta-analysis or a systematic review around the savings made from smoking cessation. And I wanted to finish with this quote here. I've just gotten off the phone after discharging a client and his wife that, working closely with both of them, was just saying how appreciative she was because she felt she was hitting her head against a brick wall before, to come on board, that she felt she was getting nowhere with the doctors, even though she had lots and lots of concerns. She could see her husband deteriorating in front of her eyes, and just being able to navigate the system and work on not just one goal or a small number of goals, but actually over time we've been able to really address multiple goals. Thank you everybody for listening to me today. It's been such a whistle-stop tour of this project. The take-home messages really are, these roles are incredibly valuable, incredibly impactful. We need to think about how we address client needs, not just in terms of the type of professional that addresses those needs, but the core values and attributes and those technical skills that we really need in order to unpack and address these complex needs, and the system needs to value these roles more. Thanks so much.